Okay, good morning, good afternoon, and good evening, everyone. So my name is Tersit. I'm a global primary healthcare program lead at the International Institute for Primary Healthcare in Ethiopia. So thank you for joining us today for this important session. So to say a few things for those who join us for the first time here. So this is a monthly webinar series focused on primary health care. So we have been doing this learning exchange with different countries' experience for the last 4 years, and it has been a very good experience with all of you. So thank you for being with us with all this time. So today we'll be having an important session regarding to the equity related to the maternal and newborn health. So we have distinguished speakers from Ambref, Ethiopia, JSA Ethiopia, and also from Zambia. So, and we have a webinar from a colleague from Johns Hopkins University, Emily. So it's been an honor to have you with us today, and I will be starting with the introduction of the moderator, and I will be handling for her. So today it will be Emily Miller who will be moderating this session. So Emily is joined Johns Hopkins in 2020 and supports a diverse portfolio of education and learning activities for public health workforce capacity strengthening initiatives, including vaccine acceptance and community health work training. She has experience in competency-based educations, curriculum design, experiential learning, participatory teaching methods. She also passionate about global health education and transformative learning, and she's particularly interested in paradigms that preserves local expertise and embrace diverse epistemological knowledge systems. Her additional research includes using qualitative methods and human-centered design to improve community engagement to inform primary health care service design and delivery. She spent 4 years working abroad, and her professional experience has spanned a range of coordination, implementation, and M&D support for global health program and community health engagement in over 25 countries. She also spent 2 years teaching in English as a second language and is fluent in Spanish. Emily holds a BSc in public health and also a master's in global health. It's a pleasure to have you, Emily. So without further ado, I will be handling to you for your moderation. Over to you. Thank you.
Thank you so much, Tirsit, and thank you everyone for joining today. Good morning, good afternoon, good evening, wherever you are. It's an honor for me to introduce our first presenter today, Dr. Karen Chizuni. Dr. Chizuni is a registered nurse midwife, and she holds a master's in nursing and a PhD in public health. She has over 15 years experience in management positions and over 20 years experience in primary health care. She currently works as the Chief Safe Motherhood Officer at the Ministry of Health headquarters in Lusaka, Zambia. Without further ado, I would like to pass it over to you, Dr. Chizuni. Thank you.
Thank you so much, Emily. So because of the challenges with the internet, I will not keep my video on. So I'll be able to switch off my video so that I can have quality internet. Thank you. Thank you so much. So we'll be looking at equity of action, prioritizing vulnerable households in maternal and newborn healthy, looking at interventions that are being implemented in Zambia. Next slide. So when you look at the outline for the presentation, I'll give an introduction, then I'll also look at the current status of maternal and newborn health in Zambia, then also be able to look at the barriers to accessing maternal and newborn health services by vulnerable populations. Then I'll also be able to look at the prioritizing vulnerable populations or households in the Zambian context, and also finally look at the key messages. Next. So Zambia has made progress in terms of reducing maternal as well as newborn healthy, and also ensuring that there's access to maternal and newborn health services. But special attention may need to be actually focused on marginalized populations, including adolescents, as well as those populations that are in the rural areas of the country, including those that are living with disability. So emphasis has to be placed on ensuring that those key populations are able to access maternal and newborn health services so that we can be able to reduce maternal as well as newborn health complications as well as mortalities. Ensuring that health services are actually accessible by everyone that needs them. So this we are going to do by ensuring that we strengthen the implementation of services through ensuring that those that are in hard to reach areas are reached using either mobile or outreach services. Next. So when you look at maternal mortality, Zambia has made a lot of progress in terms of reducing our maternal mortality ratio from the 648 that you see in 1992 to 187 per 100,000 live births in 2024. However, disparities still remain. When you look at the fertility rate has remained high at 4.7, with the majority of those in the rural being affected. And also, when you look at the adolescent pregnancy rate, it has also remained high at 28%. And the maternal mortality ratio is still affecting those that are aged between 20 and 29 years old. So meaning that we still have disparities in terms of those that are having access to services, and also in terms of the mortalities that we are seeing as a country. Next. So when we look at the fertility rate, we reduced the fertility rate from 7.1 in 1992 to around 4 in 2024. But when we look at the urban versus rural, you will see that those that are in the rural are proportionally affected because their fertility rate is still high at 4.9 compared to those that are in the urban who are at 3.2. So we still need to come up with the interventions that will be able to help us reach out those that are in the rural so that they can also be able to access the services. Next. So when you look at teenage pregnancies and also looking at who is affected, you find that those that are in Eastern Province, for example, Eastern Province is a rural province, and we had the highest number of teenagers that had pregnancies before age 20. And we also look at those that had access to education. You see that those that had no education actually had a higher chance of falling pregnant. We had around 34% of those that had no education actually presenting with teenage pregnancies. And also, when you look at the wealthy quintile, you actually see that those that are poor or in the lowest quintile actually were also more affected than those that were in the higher quintile. So these disparities are still there, and they could be contributing to the teenage pregnancies that we see. Next. So when you look at the vulnerability that is faced by those adolescent girls that are pregnant, you actually see that they tend to have stunting affecting their children. And then also look at the issues of mortalities. They tend to lose their babies, and also sometimes they tend to die because it's either they are in the low social status and they can't manage to have access to quality maternal health services, or their babies tend to die because they are also not able to access services that they need. And then also when we look at the brain, they tend to have impaired brain development because of the poor nutrition that affected the mother whilst they were in utero. And then for the mother, you see that they tend to engage into intergenerational cycle of malnutrition as well as poverty, because if the mother did not go to school, chances are very high that even the child that they're going to have will not have a chance to go to school. And then when we look at gender inequalities, they tend to be affected the most in terms of gender inequalities that are manifested by issues to do with the low finances, as well as the issues to do with powers. Because majority of these teenagers, they tend to marry men that are older than them, and they do not have the chance to actually make their own decisions. And then this also increases their vulnerability to sexual and gender-based violence. Next. So we tried to look at the issues that were affecting or contributing to these teenage pregnancies, and looked at issues to do with policies. We also looked at the place where these were happening, as well as the people that were affected and the processes. So we find that there are a number of issues that surround teenage pregnancies, and yet we have not been able to identify exactly what needs to be done to address these issues. So we find that our teenage pregnancies has remained high because the majority of these issues that are here that could be contributing to the teenage pregnancies have not been addressed. So I can cite an example of policy issues where we still have a number of conflicting laws that are in the country. For example, we have the the age of consent for sex at 16, whilst this 16-year-old cannot have an opportunity to make a consent or make a decision for them to access contraceptives at age 16. They can only be able to access the contraceptives without a third party when they are at age 19. So those conflicting laws actually tend to contribute to these teenagers or adolescents having unintended pregnancies that actually tend to threaten their progress in life, including that of their babies, and they remain vulnerable for the rest of their lives. Next. So when you look at child mortality, though we have made progress to also reduce child mortality, our infant mortality has remained high at 17 per thousand live births, far higher than the global target of reducing the neonatal mortality to at least 12 per thousand live births. So majority of these babies that tend to die, you find that the mothers could be young, or they could be babies that are born to women that are poor, or it could be babies that are actually born to mothers that did not go to school at all. So the vulnerability actually tends to increase the chances of these neonates dying. Next. So what could be the barriers to access? So we looked at the demand side as well as supply side. So on the demand side, we looked at the economic barriers. I think issues of cost of services. Sometimes they are supposed to pay for the services that they are accessing. We find that sometimes we find these women, they could be living in an area that is very far from a health facility, and they need to find money for transport for them to go and access family planning services, for example, or maybe to take a child for immunization. And sometimes you may find that they may have transport to get there, but they're told to say they needed to buy a book, or maybe they needed to buy a syringe that is not available at that particular time. Then also knowledge and education, you find that sometimes these mothers or adolescents may not be aware about the availability of the services. And because of that, they tend to come very late when the condition is actually worsening. Also issues of high literacy levels. We still have high literacy levels amongst women because we still have girls that do not go to school at all. Then issues of culture as well as social barriers, we looked at traditional beliefs and stigma. So there's still a lot of stigma that goes on with the use of contraceptives, for example, for teenagers, and this actually prevents them from accessing services. Then traditional beliefs, there are beliefs where when this teenager attains menarche, so they may need to sleep with an elderly man so that they learn how to take care of those men when they get married, but those things are done too early for this particular child. Then also issues to do with child marriage. Sometimes you find that when a child attains menarche, they still have traditions or populations that tend to marry off their girl children. And sometimes this girl child may just had an unintended pregnancy, and they think that once they have this unintended pregnancy, the best option for them is actually to get married. Then on the supply side, we looked at limited health facilities and infrastructure. So we still have villages or households that live very far, more than 10 kilometers away from the health facility. And these, they tend to have challenges with access to services. The limited number of ambulances for referral. So sometimes we find that this woman may actually go to the facility very early and she has a complication, but there is no ambulance to actually transfer to her facility where she can have access to cesarean section, for example. Then also health workers' attitude, you find that the attitude of health workers tend to hinder the access to services. For example, for those women that have not gone to school, those that are poor, because when they look at them, the way they are dressed, the way they approach them, some healthcare providers may not be able to accept them. And because of that, access to services is delayed. Then capacity building gaps. So we still have challenges with our training. Though we are able to train as many healthcare providers as possible currently, the quality of the training tend to be compromised because of the numbers. When you look at the ratios between those people that are training, who are lecturers or the tutors, against the learners, so the numbers are high, meaning that the contact is actually less, and sometimes even practice becomes difficult because we have few facilities that are offering training. Then also overburdened healthcare providers, because the healthcare providers are few, they tend to be overburdened by the numbers of mothers as well as newborn babies that come to the facilities, and they may not be able to provide quality services. Next. So prioritizing vulnerable households. In Zambia, interventions that we provide in Zambia include community engagement and involvement. So this is critical for the populations that are vulnerable, especially those that are in the rural areas. So we have trained community-based volunteers that are able to actually provide the maternal and newborn health services within the community. These include the community health assistants. We also have safe motherhood action groups. We have peer educators that also provide information to adolescents, and also the community-based distributors of family planning that are able to distribute family planning services within the community. But the challenge still is that they are only able to provide short-term family planning methods. Then also tracking of zero-dose communities. So we look at those children that have never received any vaccine. So those are also followed up by the community volunteers to ensure that they are vaccinated. Then also training and empowering community health workers. So we also created a cadre that we are calling the polyvalent worker. So this polyvalent community health worker is able to get a lot of information around integration of maternal and newborn health services with other programs like TB, HIV, so that when they're in the community, they're able to provide a comprehensive package. Then also looking at counseling on nutrition, early child development, HIV, and STIs, including adherence to treatment. So we have a program that we are calling Mentor Mothers, and these Mentor Mothers are able to actually provide information on adherence to HIV treatment, and also ensuring that these mothers, including young mothers that may not go to the facility to access services, are able to receive their treatment and are able to adhere to the treatment for HIV. Next. Then integration of health services, so comprehensive maternal, newborn, as well as child health services are actually provided in an integrated manner. So when you go out for outreach, for example, we don't just provide immunization for the child, but we are also able to provide family planning services. We are also able to do antenatal care services to ensure that women do not have to walk to the facility several times, or maybe because outreaches are actually done once in a month. So when we get there, we are able to provide comprehensive packaging so that if the pregnant woman has a child that is under 5 and still receiving immunizations, they're able to receive that within that same visit. Then also accessibility initiatives. So we are using both the mobile clinics and also integrated outreach programs. So we have divided our populations into catchment areas that we are calling zones. So these zones have dates when outreach activities are done. And we do this together with our community-based volunteers to ensure that all women as well as children have access to services at least every month. Next. Then policy and advocacy. So under policy and advocacy, we are ensuring that there is availability of supportive policies, including strategies as well as guidelines that we have developed and printed. So these are able to actually guide the healthcare providers in how services are going to be provided. So we also have guidelines, for example, that look at outreach activities, and also guidelines that look at integration of SRH services with other services. Then advocacy strategies, we are looking at engaging stakeholders, building coalitions, as well as lobbying for resources. So we have to ensure that we have sufficient use of resources by one plan. So usually what happens, even if we have partners that are supporting SRH and child health activities, we make only one plan. So we have one strategy and one action plan that is developed every year, and all the partners buy into this action plan and implement together. Do the monitoring together, we are using one monitoring framework, and also we make sure that we are able to implement these actions, action plans together. Then also, we also look at using the tool that everyone is able to access. So we developed the RAMCAN communication and advocacy strategy. So this tool has messages that speak to each audience. So, for example, we have messages that speak to men, we have messages for females, adolescents, and so on. Then, under monitoring and evaluation, we use the standard data collection tools to track health outcomes as well as service delivery. And these same data collection tools are used everywhere, including in the rural areas. Then also conducting surveys and interviews as well as focus group discussions. So, and periodically we do go out to actually do surveys to just get to know what our population need, and also get to understand how the services are being accessed. That's how we are able to know to say actually those populations that are in the rural areas are actually vulnerable and are not receiving adequate services. Then data-driven actions, we are also ensuring that we use data-driven actions. So we refer to our data to come up with the plans that I talked about earlier, and we periodically look at these actions to see whether we are improving or not. Then also continuous improvement and responsiveness using quality improvement. So that fishbone analysis that I showed you is what we use to actually identify the areas that we need to focus on in terms of interventions that will be able to address the root cause. So root cause analysis is basically done using root cause analysis tools like the fishbone analysis that I mentioned earlier. And then thereafter, we're able to come up with the QI projects that the facilities implement, and periodically they're able to monitor and evaluate themselves and see whether they are actually be able to increase access to services or not. Next. So for takeaways, we are saying that it's important to prioritize vulnerable populations because the vulnerable populations also need access to services. Sometimes we may think that those that are in the peri-urban areas are better, but when you look at statistics, it may tell you to say actually those are also left behind and they also need to be prioritized. So need for community involvement as well as policy support. So as we plan for activities, it's important that we engage the community, including the recipients of the care, so that we can hear what they have to say and also be able to identify their challenges that can be addressed. Then also addressing the cultural myths and misconceptions. I mentioned that we still have myths and misconceptions that are surrounding pregnancy as well as child marriages. So these need to be addressed if we have to ensure that we address the issues that are affecting the vulnerable populations like adolescents. Then also multi-sectoral approaches. So as a Minister of Health, we have learned that we cannot be able to finish the problems or end the challenges that the vulnerable populations are facing, but we need to engage with other line ministries to ensure that those are addressed. I mentioned about issues to do with poverty that actually is affecting our teenagers and also contributing to a high number of teenage pregnancy. So if we work with the social welfare, they'll be able to identify those vulnerable girls and ensure that they remain in school. So for call for action, we are saying that we need to encourage collaboration among multi-sectoral stakeholders to enhance maternal and newborn health equity. Thank you.
Excellent. Thank you so much, Dr. Chizuni, for that presentation. And I see we already have some great questions coming in, but I think we are going to hold those until we've heard from our second presentation. So with that being said, I would like to go ahead and introduce our next two speakers. First, we have Dr. Chizachu Tadeli-Turun, who is a seasoned public health scientist with over 2 decades of experience in measurement, evaluation, and implementation science research. He's led the design, monitoring, and evaluation of large-scale maternal and child health, community health, and primary health programs, and multiple implementation science research initiatives embedded within broader maternal and child health and primary care service delivery programs in Ethiopia. He's engaged with the academic community as a faculty member at Addis Continental Institute of Public Health, teaching and mentoring Master of Public Health students to build the next generation of public health professionals. He holds a BSc, MPH, and PhD degrees in public health and has published over 31 papers in peer-reviewed journals. We'll also be joined by Dr. Agumasi Samagan, who is a distinguished public health professional with over a decade of integrated experience in academia, research, and program implementation, measurement, and evaluation. He earned his PhD in public health from the University of Ghana and has completed postdoctoral training with a focus on implementation science research. Currently, he serves as the Senior Implementation Research Advisor for the Improved Primary Healthcare Service Delivery Project at AMREF Health Africa in Ethiopia. He leads a VHL-led community-based initiative that delivers life-saving health packages to pastoral communities, where access to and utilization of facility-based essential health care remains limited. He's the author or co-author of more than 50 peer-reviewed articles published in reputable open access journals. He's also dedicated to mentoring the next generation of public health professionals in Africa, guiding master's, clinical trial, and PhD students in public health. He will address the necessity of a context-tailored life-saving intervention delivery platform, Evidence to Action for Equity, drawing from his extensive experience and commitment to advancing health equity in underserved populations. Thank you both again. We're very happy to have you here, and please go ahead with the presentation.
Thank you so much, Emily, for the kind introduction. So me and Dr. Agmase will present our collaborative work, which is community-based delivery of life-saving maternal and birth interventions in remote agrarian setting as well as pastoral settings which has very low utilization of facility-based care. So this is an embedded implementation research which has been implemented by JSI and AMREF, JSI in agrarian and AMREF in pastoral settings. This work has been providing an oversight from the Ministry of Health and also the Research Advisory Council of the Ministry of Health. We are representing this research team and implementation team as well to present our work so far. So I will be presenting the first part, and Dr. Agmase will continue with key findings and the lessons we have so far. To start with problem statement, as we are aware, though there are global investments and national commitments and investments to improve maternal and child health, still the uptake of maternal and birth care services remains low in low-income countries, including Ethiopia. And particularly, the remote agrarian and pastoral communities face high barriers to access to these essential maternal and born services. These are due to geographic inaccessibility and also social, cultural, and gender barriers contribute a lot for this disproportionality or high vulnerability for these communities. And as such, many maternal and newborn diseases happen at community level. Global literature showed community-based delivery of such type of life-saving interventions for maternal and newborn has resulted significant improvement in access and utilization of these services. In Ethiopia and other low-income countries has also been tested. These community health workers can deliver misoprostol, iron, and also family planning services to such vulnerable communities. However, the scale-up of such life-saving interventions has been uneven due to policy issues and also the non-evidence-based or concerns from program managers and policy makers. For instance, misoprostol has been distributed in advance at community level in Ethiopia in 2014 and before by community volunteers and health extension workers. These are frontline workers, but later scale up has not been done due to the concern from the policy makers. As a result, JSIN and AMREF has been implementing, improving primary care service delivery to improve access and quality of maternal and child health services since 2022, and now on the fourth year. It is a 5-year project. On this platform project, we have embedded an implementation research to test the feasibility and acceptability as well as effectiveness of community-based delivery of these maternal and border health services, including misoprostol, iron, and postpartum family planning, and also test the feasibility and acceptability of postpartum learning and actions cycles to enhance women's agency to seek maternal and border health services. So today we'll be presenting the key lessons from these two innovative strategies that we have been implementing, embedding in the larger committee's program. And this innovation has been implemented for the last 1 and 6 months, 1 year and 6 months. And we concluded in September, the last September 2025. So it has two objectives. One is designed community volunteers-led service delivery for maternal and born health services, including misoprostol, iron, and family planning, as well as chloroxetine for newborn care. And the second is for postpartum and learning action to enhance women's agency to seek care and also improve access to these life-saving interventions. So the interventions has been packaged into like misoprostol for home births, prenatal iron supplement, chloroxetine, postpartum family planning, promotion of facility births, and residential newborn care, and also postpartum women's group meetings at community level to identify their problems and design solutions to mitigate those problems. The strategies we have been deploying and training community volunteers, we call it village health leaders, VHL. Now, hereafter, I will talk about VHL, which is community volunteers, which are actually committee. They are selected by participatory way in a community level. They are gender mixed or balanced, and also they have a grade of 6 level education. So they are volunteers, they are closely working with the community and their system. Continuous identification of pregnancy, enrollment, and doing home visits by these community volunteers to these pregnant women to educate and also distribute these life-saving interventions as well. And also establishing and implementing the postpartum and learning action cycles at community level, and strengthening referral and maternity homes where the strategies we have been employing. So the intervention delivery, particularly for the first innovation, which is community volunteers-led maternal newborn service delivery to deliver misoprostol, iron, chloroxetine, and postpartum pills. They are instructed to carry out 3 home visits, 2 antepartum, and the last one is a postpartum visit, to educate women and distribute iron, misoprostol, and other life-saving interventions. Sorry, there is a heavy rain here. If you are able to hear, I can continue. If not, Dr. Agmasi will continue. Let me know that. Regarding participatory in learning action, it has 40 cycles grouped into 4 phases. The first phase is identifying the problem, the community level problems to seek maternal and child health care, and identify solutions to mitigate these challenges, and also they design solutions and implement these solutions, and finally they will evaluate and plan for the next phase. Particularly, they identified geographic barriers and also distance barriers to seek care as one challenge, and also remoteness. Due to remoteness, they also propose establishing maternity homes at a central level. To mitigate the cost and travel issues, they also provide cash for pregnant women to travel to health facilities as well. To facilitate this, we recruit and deployed village leaders or community volunteers to facilitate these village level meetings as well. In terms of the study setting, as I mentioned earlier, this has been implemented in very remote agrarian areas. One agrarian area for community MNH service intervention, we call it Zaka. We selected Kabbales of this Warada and also Chefra and Gavrov in pastoral geographies. For the participating in learning action, we have implemented in 4 waradas, 1 in agrarian and 3 in pastoral waradas. With a similar characteristics and background characteristics, we also selected comparison areas in agrarian also, as well as pastoral geographies to have similar contexts with the intervention areas as well. So this is a quasi-experimental implementation research project with a 4-arm. One arm has been community distribution of maternal and border services, including misoprostol. The second arm were participatory in learning actions. The third arm combining MNH and PLA. Both these 2 arms we have implemented in pastoral settings, and the fourth arm were control areas. So this was before-after contour household survey and also stratified by agrarian and pastoral and also the intervention domain as well. For the evaluation purpose, we did a formative assessment at the beginning, like in August 2013, involving household surveys of about 3,000 women and qualitative study to set baseline and also identify implementation challenges. During the implementation period, we have been closely monitoring the implementation, and we did a process evaluation, like establishing a longitudinal database system to track all interventions that has been implemented. And as in the line in September 2025, we did a household survey and also a qualitative inquiry as well. I think we monitored this implementation outcomes, the reach effectiveness, implementation fidelity, acceptability, and feasibility, which Dr. Agmase will talk later. In terms of analysis, we stratified by domains and agrarian setting as well, and the qualitative we have been trying to analyze thematically. I think this is all from my side. Over to Dr. Agmase. Thank you so much.
Thank you, Dr. Gzo. Let me share my slide. I'm trying to manage it, and otherwise, Gzo can also display and then move the slide if the rain is not that much affecting you.
Yeah, I can, yeah.
Yeah, just continue the display, then I can move on that, yeah.
Good.
Okay, thank you so much, particularly Institute for Primary Healthcare, to invite us to share our key lessons from the implementation research, as Dr. Gzacho presented, particularly for the design and the process that we have gone through for a year and a half. Ladies and gentlemen, can you hear me?
Yes, we can hear you.
Yeah, thank you so much. That we have been, going through to design this intervention to reach particularly the community who are vulnerable, who have geographical access issues, the climate and different mobility because of their lifestyle in the pastoral, and also hard to reach in the agrarian areas. So that takes actually the design took a long period of time that involve officials from top leadership to the community level to design this intervention. So I'm going to just mention some key lessons that we have learned in the process and how we ensure the implementation fidelity feasibility, acceptability of the intervention, the safety, because we have been distributing some life-saving interventions through community volunteers who were actually under supervision by the health extension workers and also healthcare providers in the study areas, and are also the managing by the Warada health officers. And I'll also present the effectiveness of the intervention. Next slide. So when you see the implementation fidelity of our implementation research and the number of people who reach, particularly the vulnerable women, so we design this intervention delivery process a bit in a different way because Ethiopia is well known in health extension program and health extension workers who are salaried, but we just designed this intervention to be delivered by community volunteers. We call them village health leaders under supervision of those health extension workers. We designed this implementation or delivery strategy with the community, and also the healthcare staff over there. So we agreed those village health leaders can distribute these life-saving interventions, and we recruited and trained 187 village health leaders and deployed to the communities around 38 kabalis or sub-districts in the Ethiopian context. Those village health leaders initially identified pregnant women through their own social network. We didn't use those laboratory tests to confirm pregnancy because access to such kind of laboratory services is very limited, and it's difficult to provide such kind of laboratory service over there. So we co-designed this intervention with the community, and also we conducted context assessment using the focus ethnographic studies to know how women in the remote areas or the pastoral and also in the agrarian context disclose their pregnancy, because pregnancy considered by our community a bit is a blessing. They don't want to disclose it. They want to hide it, and they don't want to keep it for themselves and also for their very close families. So we found that women, particularly when become pregnant, they disclose to the very close families members, and also the traditional birth attendants were famous, particularly in the pastoral areas. Then the second option that we use to identify pregnant women is visible pregnancy. So once the pregnancy is visible, the village health leaders who are living in that community identify the pregnant woman and report to the health extension workers to enroll to our cohort to provide the interventions, supplies, and other behavioral change communication interventions. We identified more than 4,000 pregnant women from 35 kabalis using the village health leaders through self-disclosed and visible pregnancy method. And once we identified and enrolled them, we planned 3 consecutive visits to provide the necessary life-saving interventions and prepare the pregnant woman to give safe delivery, and also to enhance them to give birth at its facility, because our intention was not enhancing delivery at home. Instead, facilitate referral linkage and other means to take that pregnant woman to give birth during their period. So the first contact or the first visit was mainly promoting antenatal care and linking the pregnant woman to the health facilities, in collaboration with the health extension workers, and provide the folic acid, iron and folic acid to the pregnant woman, and capture necessary informations particularly basic information and link to the health facilities for antenatal care. That's the first visit was less than 7 months, but the second visit is the woman when become from 7 months to 9 months. Keep in mind we didn't use those technical jargons because those community village leaders and the pregnant women are not aware of those gestational ages and other things. Instead, we used the means to count their gestational age. So from 7 months to 9 months, that was the second visit that the village leaders were following and provide that life-saving package that include misoprostol, chlorhexidine, the postpartum family planning option, and also some newborn care supplies like for cord ties and also hypothermia prevention supplies just to prevent hypothermia and also infection. Just a woman, if a woman gives birth at home, she has to at least put some clean plastic sheet to prevent infection. So when you see the overall flow, that was good, and the village leaders adhere to provide necessary interventions along with the life-saving package intervention, because we provide them well designed using the human-centered design approach, information materials, and also other very pictorial kind of information delivery mechanisms to the VHL and also the beneficiary, so the vulnerable woman. Next slide, please. So when you see this implementation feasibility and acceptability, we planned very well ahead just to enhance the feasibility and accessibility because we passed through iterative co-design process from the top leadership, the Ministry of Health and other key stakeholders at the central level, and down to the community level. That's a really enhanced the feasibility of delivering this intervention through in collaboration with the local health system. And also this intervention design, just to integrate with a bigger project that Dr. Gizacho presented, the Improve Primary Health Care project, and the providing the ownership to the local health system and also delivering this life-saving intervention by the community members who are the village health leaders, enhance the visibility of the intervention and acceptability by the community or by the community and also the direct beneficiary of this intervention, the pregnant woman and also her close families. VHLs who are actually originated from that village, so they are acceptable because we recruit village health leaders who are active, a bit educated, and also well accepted, well recognized community members to enhance the usability of this intervention. And we design culturally sensitive interventions and also delivery mechanisms of this life-saving intervention with the community members and opinion makers over there. That's why they accepted the intervention, and we passed through a very smooth relationship with the community, and we found a wonderful finding. And a mother quoted the service provided by the VHL were extremely helpful. Their advice where to give birth when just linking to NC and in a postnatal visit as well. It was very helpful that remarked by the women during our process evaluation using a qualitative method. Next slide, please. When we see the safety, particularly, there was a concern when we initiate this life-saving package delivery modality to the hard-to-reach areas or the vulnerable communities, particularly if the community members or anyone who may use misoprostol in a different way, and also chlorhexidine that is a bit harmful. That means careful management. And also there was also a fear this community-based life-saving delivery may facilitate home births and that may affect the institutional delivery. So when you see this one, when you just follow up those more than 4,000 pregnant women and who received the life-saving package. So we found, particularly those who give birth at home, they used, the misoprostol correctly. More than 96% of them adhere to the information that we provided when they should use misoprostol while they give birth at home. If they didn't give birth at home, we advise them to take it to the health facility while they went to the health facility to give birth over there. And chlorhexidine and other supply applications were relatively safe. When we say no adverse outcome that's related to our intervention, and also consider that we had a bit immediate follow-up after postnatal. So we may not, account, after our visit that happened postnatally. So that is what I want to just remark. Overall, the utilization was good and it enhanced facility delivery because we were providing interventions to strengthen referral linkage. And the women-centered group over there who were applying participatory learning, and also the women group and the community engagement structure also enhance women to give birth in the facilities through our awareness creation and the platform that we create community referral linkage that really enhance facility births. But still home births is high over there. But when I'm saying those facility births improved, but still home birth is high that requires further such kind of life-saving delivery modality. Oh, next slide. So those are the findings that we found just to assess the effectiveness of our community-based delivery of this life-saving package. When we see the overall particularly some of selective indicators, that's antenatal care linkage, institutional delivery, maybe and also adoption of the postpartum family planning and the newborn care, particularly delaying buzzing of a newborn. Those are significantly improved when we look at our intervention before and after against to the control areas. So this intervention really gave us good lesson that we can improve antenatal care linkage and institutional delivery and newborn care as well through capacitating villages leaders and strengthen the linkage of the village health leaders who are providing just information to the women and also the health system. That really an important finding that we have observed and also found. More rigorous research findings will pop up because we are also doing the analysis since we completed the follow up and in September and also conduct the inline evaluation. So more relevant findings will generate, and I think most of you and global research communities will access our research findings. We'll try to publish and in open access journals. Next slide, please. The second modality of the intervention with the participatory learning and action. This one is women-centered participatory learning and action that allows a woman to exercise their autonomy and also to identify the community problems and plan actions to solve the community problems over there. So we established a total of more than 250 PLA groups that enhance participation of more than almost nearly 100,000 community members, which allow to involve different segment of community members. Women, that's we encourage to involve in the PLA group, and the pregnant women as well, and the men and boys engagement were encouraged, and significant portion of men and boys were also involved. And also, persons with disability over there was also encouraged to involve in the PLA group. That's, comprised 25 to 30 core members who were chaired by chairperson, secretary, and also they have treasurers who collect, their contribution and also mobilize different resources over there. We trained, facilitators who arrange a meeting on a monthly basis. So they pass through 11 cycles and discussed on different maternal and newborn health issues. And they identified several maternal and newborn issues, and also, deep dive on the barriers and also the risk factors that really hinder them to, get, facility-based maternal and newborn health services. So on average, even though we cover, nearly 100,000 community members, so the monthly average meeting was around, 16,000 that comprise pregnant women, youth, and men engagement. This is really this intervention, gave us an evidence that locally driven, intervention is really important to address, local solutions identified by the women centered group that facilitated by the women, and also, supported by actually who are volunteer, willing, and also, champion men over there. Next slide. This, particularly the PLA, which was also, is acceptable and it was feasible to implement because we deep dive and design the intervention with the community and the community members who facilitate the PLA groups that allows them to openly discuss about their issue, and that show us PLA group can be integrated to the existing platform because we nested those groups from the existing community engagement structure, who are really crucial to solve the community problems through very minor capacity building intervention that we provided, and we provide actually the training as well as the job aids, which was designed that consider the community context over there. So the facilitators really do the marvelous job, without that much a critical challenge, except those busy with their routines and other thing. So the community members also give testimony that PLA facilitators and also the PLA group that they held in a monthly basis really allow them to discuss about their issue, that respect their value, their culture, and also address their challenge over there, and enhance women to exercise their autonomy and allow to make decisions on their own health and also their own newborn, and also the community issue. They mention different critical points during our process evaluation and also inline evaluation. The participatory learning and action actually improve the women's agency that we compute using the 4 domains. That's in gender equitable norms, women access to and control over resources, and financial power, and other autonomy that enhance the women's agency that we found from the PLA sites that they pass through in the 11 in the 10. Now they're approaching actually the last round. We are currently preparing for scale up. Next slide. This is the evaluation, the quantitative evaluation that we found that that PLA participatory learning and action methodology really improve women's utilization of facility-based essential maternal and newborn health services that enhance antenatal care, the institutional deliveries, because these PLA groups have different platforms to support each other. They generate their own income. They had a contribution, monthly contribution, and also they mobilize the community and their group members as well to improve some infrastructures. They try to just construct locally made roads in the community just for the locally used the transport like bajaj we call it, and motorbike as well. And also some places they clean up some places that is really a challenge for the local ambulance. So
Sorry,
they clean
Dr.
up that
Agumasi.
road and enhance the ambulance utilization by the women and others. Next slide.
Yeah, please try to wrap it up in 2 minutes so
Next
that
slide. It's almost I've already said. I have only one slide.
perfect. Thank you.
Next slide. Yeah. So while we implement, this intervention, we had, some challenge and also some facilitators that we learned in the process. Some, just minor challenge and over there. So those are, some vehicles, they have, some turnovers. Some of them are maybe a bit busy for their routines, and also some, government office a bit bureaucracies. Even though there are also, committed leadership who oversee this intervention, really watching, this evidence for the last 1.5 year. I really appreciate, and in particular, the top leadership at the Ministry of Health to the district level. So their commitment, their willingness allow us to just pilot this intervention, was really one of a facilitator and oversee this intervention that enhance the community engagement and timely ethical approval and renewal of this protocol twice by the Ethiopian Public Health Association as well. Next slide. So, what are the lessons that we have learned in this community-based life-saving package delivery, which was not actually common in our country, even though some attempts were made so far. But this is a proven intervention from different countries, and there are literatures that recommend, community-based delivery of life-saving package, including misoprostol, and recently actually recommended by the World Health Organization. So we learned that capacitating the local system is really critical and also helpful to deliver life-saving package interventions in acceptable, safe and effective way. And we learned the necessity of further necessity of alternative mechanism to deliver services. We know the weakness of the health system or the barriers that really not compatible to the pastoral communities, which is predominantly Muslim. The staff deployment that considers gender issue, particularly midwives and other clinical providers, is very important thing. And if all pregnant women come to the facility to give birth, I think I doubt that the system itself may carry this load. So always we have to find a way to deliver services to ensure access to health service. That has to be considered by the policymakers and program implementers. And our intervention really enhance the local solution for local problem, because those intervention enhance the women's agency and other segment of population's engagement. And iterative co-design is very important. I think we should not be prescriptive. We have to listen the community's voice, and we have to be consultative to get our intervention acceptable and effective. Thank you so much.
Wonderful. Thank you so much, Dr. Agumasi and Dr. Jazatu, for that presentation. That was really interesting. And we have so many questions already that we'll try to get through as many as possible. And also some of these are being answered by chat as well. So the first question is actually for Dr. Chizuni. And the participant is asking, with respect to the key barriers that you mentioned on your slide, the only demand side and supply factors were mentioned. And the participant is wondering if you could speak on the social and structural determinants of maternal health services, such as women's empowerment, and some of the major determinants of maternal health and how those would fit into your framework. Thank you.
Yeah, thank you, Emily. So, yes, I think there are also social determinants of maternal health services that I did not speak to, like women empowerment. Yes, women empowerment actually is critical to accessing services by women as well as the children that they have. So when we look at what we are using in Zambia, we have identified those vulnerable women and we are providing with the social cash transfer. So they are able to receive some funding that actually helps them to access antenatal care services. And also for the adolescent girls, they are also getting some money that is actually helping them to continue being in school in terms of paying school fees as well as the other essentials that they need, for example, sanitary towels. So that is actually and something that we identified as a challenge as well and tried to address it. Then also issues to do with education. So we also have a policy for free education. So this time around, children can go to school, those that are in primary as well as secondary school, those that are day scholars, they go without paying. So, and those that are at secondary school, they are required to pay a minimum amount of 1,000 kwacha. So it is very minimal and it's affordable. And then also have the re-entry policy for those adolescents that have fallen pregnant before they complete their school, they are allowed to go back and finish their education. Over.
Great. Thank you so much. I think that makes a lot of sense. One of the questions that's come up actually a couple of times, so I think it would be appropriate if we could have everyone on the panel sort of respond. But there are a lot of folks that are wondering what can be done to address these major gaps that we're seeing between urban and rural contexts. So I don't know if I could maybe pass it over to you, Dr. Gazachu and Dr. Agumasi, and then we could also have Dr. Chizuni respond in that order.
Okay, thank you so much. Sure. I think mainly the national government's role, and particularly for Ethiopia, the national strategies has been addressing inequality and overall the health system is decentralized since we have very diverse contexts and most strategies have been contextualized to that local context. However, still the pastoral communities and hard to reach communities, particularly rural communities, have still multiple challenges that has not been really addressed through the national strategies, the current national strategies, which need is special attention and special strategies very tailored to the community. For instance, as I mentioned, agrarian communities has been treated with a similar strategies, agrarian, but in agrarian communities, there are quite different contexts there as well. Some have very difficult topographies to reach health facilities to seek care, while others have a good access. And in pastoral communities as well, there are very peculiar challenges like shortages of facilities, human resource, budget, etc. is very worse there, which needs very peculiar strategy tailored to that context. I think it needs also like tailored financing mechanism to such contexts as well, in addition to tailoring other strategies or implementation strategies as well. Now our evidence also shows that if you are expanding the scope of community volunteers to provide such life-saving interventions, this could also be a solution. And this is, we have tested is feasible, very acceptable, and also effective to deliver such type of life-saving interventions. But the national policy really doesn't allow, the current policy doesn't allow to, for instance, to distribute resources at community level by community volunteers. But as this is an implementation research, we implemented as a controlled setting. We are hoping this will be a national policy included in the national policy, and this would be one solution, like to provide such type of life-saving interventions by community volunteers would really solve or serve as an interim solution for such communities. Over to Agmasi.
Yeah, thank you, Guzo. I think you mentioned most of the critical points, and I really appreciate the concern that's raised by the audience. It's very obvious there are minor group or segment of population who are vulnerable even in the urban, who may not really afford the healthcare service costs. I think that needs tailored intervention, particularly the financing issue that Dr. Zo mentioned. In the meantime, the quality of service is also critical across for those group of vulnerable communities that has to be consider how we can provide equitable quality service to those vulnerable group while providing such kind of life-saving interventions and strengthening the community engagement and involving a different segment of the population can help to address such vulnerabilities even in the urban and also in the rural areas. We know that we have different modality to deliver services to the rural communities and in the urban areas, particularly like the family health initiative is particularly in the urban area. That's critical. That has to be considered. Identifying such kind of vulnerable population and enhance the utilization of facility-based care and also reaching them through such kind of delivery mechanism. That is a very important thing. I think I would like to stress more from the financing as well, and also the community engagement both in rural and urban areas, and designing tailored intervention, the intervention that can be tailored to the urban context and the rural, because the urban is a matter of affordability or the purchasing capacity, but in the rural is again the geographical challenges are the one that really affect them, and also their lifestyle. They are moving place to place, so different modality might be important to deliver such kind of services. Thank you. Over to you.
Thank you. So apart from community engagement as well as financial resources, we can also look at how we can retain the skilled providers that are available in the rural areas, because sometimes we find that they tend to move from rural to urban because of lack of social amenities. So actually making sure that schools are available, shops are also available in the rural areas can also be able to help retain the skilled providers that have been sent there. And also coming up with a retention scheme. For example, we are currently providing rural hardship allowance to those that are actually saving in the rural parts of the country, to actually try and attract them so that they can remain, so they get a slightly higher package compared to those that are in the urban area. Over.
Great, thank you. I think that makes a ton of sense and a lot of really great, thoughtful responses to that. Thank you. We're getting a lot of questions. And again, I do think that this is something that it would be interesting to hear all of the panelists speak on because there's a lot of clarification questions about the cadres of community health workers that you all have relied on for these interventions. And I think maybe a little bit of clarification on, in this context, which cadre of community health worker you were leaning on. And if you could also give us a little bit of context about how they're sort of professionalized or trained in your setting and why they were a particularly good fit to help with these initiatives. Because there's a lot of, I know there's a lot of variability, both kind of between and within countries for these types of workers. And it might help to clarify some of the audience's questions about those workers. So if we could just maybe in reverse order this time. So I could start with you, Dr. Jazuni, and then over to Dr. Agumasi and Dr. Gizachu. Could you tell us a little bit more about the particular cadre of community health workers that you were working with, and just a little bit more context about why they how they've been leaned on to support these important initiatives?
Okay, thank you so much. So we have different cadres of community health workers that are currently working in the country. So we have a community health assistant. So the community health assistant is also trained for a period of 1 year. And in the curriculum, there's also maternal and newborn health. So these are able to go into households and also identify pregnant women as well as the children and ensure that they attend antenatal care services, they deliver at the facilities, and also those that are sick, they are also referred to the facilities to ensure that those children can receive care in the shortest period of time. And they're also able to treat minor ailments. For example, those that present with the simple malaria, they are also treated within their communities. Those that have diarrhea, they are also given treatment within the community. And then we also have the safe motherhood action groups. So safe motherhood action groups are trained for a period of 5 days. And these basically provide information around maternal as well as newborn health. So they also do home visits and also ensure that pregnant women that have been identified during household visits start antenatal care within the first 3 months, and also they are able to go back for the subsequent care as well as ensure that they deliver at a health facility. So they also have a component of newborn health in there as well as family planning services and also taking care of the sick child. So those they work together with the ones that we call community newborn care volunteers agents. So these the agents also, those specifically they look at the newborn care component, but they also are able to go around the facilities, and when they find other issues that are related to maternal and newborn health, they're able to provide that information. So recently we actually came up with a package of polyvalent workers. So these polyvalent workers are on government salary, and they are trained for a period of around, I think, 10 to 15 days. So they just pick the component of health information. So mainly they're just providing health promotion as well as disease prevention around messaging and making sure that communities are aware of the health issues that affect them. So they work within their communities and they are deployed within their communities because they're identified by the community themselves. So basically we have a number of those that are in the zones, and they work together with the healthcare providers in the facilities. But their biggest role is to ensure that these women come to the facilities for delivery, because when we look at our facility deliveries, they are very high. Over 90% of the women are actually able to deliver at a health facility. And because of that, we are able to identify the complications within the facility and be able to provide interventions early. That's what has helped us to reduce our maternal mortality. Thank you.
Thank you so much. I think it's a wonderful question as well. So just to give you a context, we used the primary healthcare setting healthcare professionals and also health village health leaders. So when you say this intervention, when we design, we put the healthcare workers, might be a public health officer, a clinical nurse, or a midwife, who are assigned as a MSH focal or health extension program focal. We assigned them as a manager of this the project that we deliver to the community. Then we go down there and we used health extension workers. I think most of you are familiar, particularly the Ethiopian health extension workers who are salaried and under the government hiring system, while providing community health services to women and children, and also doing different health extension package that we know. So we assigned them as a supervisor of this program implementation. So the healthcare professionals at the health center and the health extension worker who manage the supplies, collect information were completed by the VHLs in the community, and enter to the data to tracker, and also manage the supplies and provide to the health the village health leaders one by one, according to their pregnant woman identification. Then down there, the village health leaders, those are community volunteers who actually at least completed grade 6, just to be able to read and write and complete some basic information, just to register households and provide some awareness creation, and also carry out community referrals, and also communicate with the pregnant women and postpartum women who are under the our follow-up. So, but this criteria actually, contextualized in the pastoral context, because, literacy is, very limited in the pastoral community. And also we have to have, assign a person who is, who have, at least good hearing, and also influence in the community to get this intervention acceptable. It does not mean on influencing the community, but at least the community should listen, at least what he's saying or she's saying. So we assigned gender balanced male and female village as leaders in one group, at least to reach around 80 to 100 households. It depends on the community over there. At least one village, at least they have one VHL group. So those are village health leaders who are the one who identify their pregnant women through their social network, and also through visible pregnancy in the community, who are going to do regular visits, complete the information, the checklist, and register some basic information, household and women informations, and take it to the health extension workers, and also advise a pregnant woman to go to the health facility for antenatal care, and promote facility deliveries, and communicate with the pregnant woman, if she would like to give birth at health facility. He took the
Dr. Agamasi, are you still there?
I think he have disconnected.
Okay, well, Dr. Agamasi, I think we lost you for a second. But Dr. Gazachu, is there any last minute words that you would like to kind of add on to that response before we wrap up?
I think it's well addressed by Dr. Agmasi, like the national committee volunteers context. So I think I don't have much to add.
Oh, apologies.
No worries, no worries, Doctor. Would you like to finish your thought before we close out?
I was saying those village health leaders are bridging, the community and the health system in the primary healthcare setting, and they are doing, marvelous jobs. I think you heard me that with the health action workers and the healthcare providers, those are the manager, supervisor, and distributor and distributors and facilitators are village as leaders.
Yeah, absolutely.
Yeah,
We
thanks.
did catch that. And thank you. Very, very helpful context. With that, we are at time. And so I would like to be respectful of the time of our audience as well as our panelists. Thank you all again for such a wonderful presentation. I think it was a really great learning opportunity. And I would like to also thank once again the International Institute for Primary Healthcare Ethiopia for putting this all together. And thank you as well to the audience for your engagement, your wonderful questions. I apologize we weren't able to get through all of them, but there was some really thoughtful engagement and responses there, and it's just been wonderful hearing from you all. So thank you all again and enjoy the rest of your day.
Thank you so much. Thank you.
Thank
Thank
you.
you.